Yeah, good morning to all the third year pharmacy students. So this is Dr. Sunil Kumar. So in the last class, we were discussing about loop diuretics. So we have finished the introduction as well as mechanism of action regarding loop diuretics. Let me repeat it. Loop diuretics are the most potent of all the diuretics. Out of all the diuretics, they produce maximum response. Okay, so that's why they are used when rapid diuresis is essential, and when other diuretics fails to produce enough when other diuretics fails to produce enough response, then you can go for loop diuretics. Okay, and here loop diuretics mainly act on thick ascending limb of loop of Henle. So loop diuretics will block sodium potassium chloride co-transport uh, present on the luminal membrane of epithelial cell of thick ascending limb of loop of Henle. Thereby, it is going to block the reabsorption of sodium, potassium, and chloride. Thereby, sodium, potassium, and chloride will not be reabsorbed. So, these three ions will be excreted in the urine in large amount. As a result, water will also come along with sodium, potassium, and chloride. Yeah, and that's why there will be a very profuse diuresis. And as I told you, the diuretic response goes on increases with dose. You, up to 10 liters of urine can be produced with loop diuretics depending on the dose. Okay, so let me share the screen. So what we have to discuss today. So let's discuss about this. Yeah. So this is what I mentioned in the last discussion. So loop diuretics will also increase the elimination of calcium and magnesium. So I told you, so this particular channel, which is this particular transport system, which we call it as sodium potassium chloride co-transporter. Yeah. And this is your empty tube. Suppose if this is your nephron, as I have instructed, as I have discussed last time. So there will be cells on either side. So sodium can be reabsorbed. Okay, sodium will be reabsorbed from lumen. So generally it will enter into cell, and from cell it will enter into B, means blood. Okay, and here, so sodium will be reabsorbed into the cell, that is thick ascending limb of loop of Henle, epithelial cell of thick ascending limb of loop of Henle. Then it will be reabsorbed in the blood. Okay, here you have this pump, especially a dot what I am showing. So here you have the sodium potassium chloride co-transporter. So this is the co-transporter. So loop diuretics will block this co-transporter, and thereby they will prevent the reabsorption of sodium, potassium, and chloride. Okay, and when these three ions are reabsorbed by a primary transport system, this is a primary transport system. So this uses energy, as I told you. ATP will be hydrolyzed to ADP. I think last class we mentioned ATP will be hydrolyzed or broken down into ADP plus plus phosphate plus phosphate. Okay, by utilizing this energy, so this transport system will work. It is going to reabsorb sodium, potassium, and chloride. Okay, so but here the point is the energy produced by the movement of these three ions when ATP is broken down into ADP, this energy is indirectly utilized. This energy is indirectly utilized by these two ions, that is calcium and magnesium, calcium as well as magnesium. And by utilizing this energy, hydrolysis of ATP produces energy, and that energy will be indirectly utilized by calcium and magnesium, and they will also reabsorb. They will also reabsorbed first into the cell, and from cell they will be reabsorbed into the blood. Now what loop diuretics are doing, they are blocking this channel, sodium potassium chloride co-transport, And by blocking this transport system, they are not, I mean to say that ATP will not be hydrolyzed to ADP. Okay, this channel will not function. When this channel will not function, ATP will not be broken down into ADP, or energy will not be produced. As a result, these two ions will not have any energy to utilize indirectly. That's why they will also fail to reabsorb. That's why calcium and magnesium will also separated along with urine. Okay, that is why you have increased excretion of calcium and magnesium. Okay, that is one thing. And uric acid, as I told you, I think I have even shown you this. Just a minute, I will go back. Yeah, here. Yeah, it also decreases excretion of uric acid. Okay, so this excretion of uric acid will be decreased as a result of competition. Okay, so there is one transport system which we call it as organic acid transport. Okay, so by utilizing this transport system, uric acid will always try to get out of the nephron. Means uric acid excretion depends on the transport system. This transport system will carry uric acid into the lumen. Okay, uric acid will be brought into the lumen by with the help of this transport system. That is what we call it as organic acid transporter. Okay, so in normal individual, those who are not using loop diuretics, the transport system will be very active, and definitely this transport system will carry uric acid out of into the lumen, and from lumen uric acid will be excreted. That's fine. But the problem here is loop diuretics when loop diuretics are used, the problem is loop diuretics will utilize the same transport system. Okay, it will utilize the same transport system to come to the site of action, to reach the site of action. Okay, so they utilize the same transport system to reach the sodium potassium chloride co-transporter. So that is the reason. That's why there is a competition between uric acid and loop diuretics to bind with organic acid transporter. And here in this competition, loop diuretics will win. It will bind with most of this transporter, organic acid transporter, and uric acid will fail to bind. As a result, uric acid cannot be eliminated. Okay, and as a result, there is a decreased excretion of uric acid. So that is the reason. Got it? So that's why I thought you people, there is a bit confusion going on regarding this calcium, magnesium excretion as well as uric acid, decrease in uric acid reabsorption. So that's why I have taken it again. Once again, I have explained. Okay, now coming to continuing our discussion. So here, pharmacokinetics. Let's discuss about pharmacokinetics. So loop diuretics are very rapidly absorbed. They are eliminated by kidney by glomerular filtration. Okay, by glomerular filtration, they are eliminated. They will enter into Bowman's capsule, and finally they are excreted by tubular secretion. And absorption of oral torsemide is more rapid than that of furosemide. Okay, so oral, if you take torsemide orally, it is absorbed very rapidly. Within 1 hour, most of the drug will be absorbed, but furosemide takes 2 to 3 hours for absorption. 2 to 3 hours for to exhibit maximum absorption. So given intravenously, produce a peak effect within 30 minutes. Okay, so given intravenously, furosemide or torsemide or loop diuretics will produce peak effect within maximum effect within 30 minutes. The plasma half-life of furosemide are about 90 minutes. Okay, so half-life of most of the diuretics, they fall in the range of 90 minutes. Half-life means time taken for a drug to reduce 50% of its initial concentration. If you take 500 mg, within how much time that 500 mg becomes 250 mg. So that is what we call it as half-life. Okay, and if there is a problem with kidney, or if there is a renal failure, or if there is any kidney related problems, if the patient is associated with any kidney related diseases, so definitely half life will be longer because elimination will be interfered. Most of the drugs will be reabsorbed. The elimination pattern will change, and drugs cannot be filtered properly through kidney. They stay in the blood, and as a result half life will increase. Okay, And the duration of action. Duration of action is 3 to 6 hours, except in case of torsemide, which has a longer half-life and longer duration of action. Okay, torsemide is having longer duration of action when compared to other diuretics. Okay, that's why it is given once a day. It can be given only once a day. Okay, and another important property of these diuretics is they strongly bound to plasma protein. Okay, they will have a strong plasma, that is PPB, plasma protein binding capacity. They strongly bound to the plasma protein and so do not pass into the glomerular filtration to any marked degree. Okay, so they are strongly bound to plasma protein more than 70%. As a result, the free form of the drug will enter into the glomerular filtrate, but when the drug is in combination with a particular protein, unless and until that protein releases the drug, unless and until the drug comes into the free form, it cannot enter into the nephron. Okay, that's why most of the drug stays in the blood unless and until it gets free from the plasma protein. Okay, and they reach their site of action to the luminal membrane of the cells of the thick ascending loop of Henle and is being secreted in the PCT by the organic acid transport mechanism. That's what I am saying. So they are mainly carried to the site of action by this OAT, as I mentioned, which to which even uric acid will try to bind. That is organic acid transport mechanism. Okay, OAT. Is it clear? So bumetanide and torsemide are being metabolized by CYP450. Bumetanide and torsemide, they are metabolized mainly by CYP450's pathway, that is phase 1 reaction. And furosemide, it directly undergoes phase 2, that is glucuronidation. Okay, you can see here, a drug can be metabolized by any phase 1 or phase 2. So here, so bumetanide and torsemide being metabolized by phase 1, that is CYP450 pathways, and furosemide being skip the phase 1 metabolism, and it is metabolized mainly by glucuronidation or glucuronide conjugation. Okay, and coming to adverse effects, this is also very important. Why? What are the adverse effects? So potassium loss, this is the major problem. Hypokalemia, as you know that along with sodium there is a loss of H plus, there is a loss of H2O, and simultaneously there is a loss of potassium, and even calcium and magnesium. Okay, so hence there is a hypokalemia. There is a hypokalemia. So that's why what nephrologists will suggest, they will either give potassium supplements in order to restore the potassium, or they will use certain diuretics which prevent the potassium loss, which will block the potassium channels. Okay, and thereby potassium will not be lost in the urine. Okay, either you can restore the potassium by giving potassium supplements, or you can directly use certain other diuretics like potassium sparing diuretics, which will conserve or which will protect potassium, and thereby you can minimize potassium loss. And as there is a loss of H plus ion, as hydrogen ion is lost, there is metabolic alkalosis. You can see that there is an metabolic alkalosis. The pH of the blood suddenly it becomes alkaline, suddenly it will increase, and that will result in electrolyte imbalance, that will result in severe vomiting, dehydration, abdominal cramps, okay, BP fluctuations, and finally the person may enter into coma. Okay, and along with that there is a depletion of calcium and magnesium along with sodium, depletion of magnesium as well as calcium and sodium. Okay, hypovolemia and hypotension with collapse result in sudden loss of ECM. Okay, so this is mainly seen with these diuretics because they are very potent. They produced increased excretion of sodium and water. Up to 10 liters of sodium up to 10 liters of urine can be produced in a day. That's why, so if it is consumed at higher doses, definitely it can disturb the blood volume. Blood volume, in case of hypertension, if you consume, In hypertension, blood volume will be high. It has to be brought to normal. But if you consume the drug in higher dose, blood volume will further fall down. More amount of water will be excreted and blood volume will suddenly fall down. And as a result, blood pressure will decrease and that may result in hypotension. And hypotension will result in collapse. That is what we call it as shock, cardiogenic shock or vascular shock, where the cardiovascular system fails to supply enough oxygen and nutrients to the tissues because of low blood volume. Okay, and that's why there is a sudden loss of extracellular fluid volume. There is a fall of ECM. Okay, and as a result, that might lead to even coma. The person may enter into coma, or there may be a chances of cardiac arrest. Okay, and hyperuricemia is one of the problem, as I told you. So uric acid and loop diuretics, they will have a competition to bind with the same transport system, and that is what we call it as OAT, as I mentioned several times, organic acid transporter. And here loop diuretics will bind with this transporter to reach the proximal convoluted tubule. Okay, and whereas uric acid will not be given chance to bind with OAT because of the loop diuretics. Loop diuretics will block the uric acid. Instead of uric acid, it will bind. Okay, and thereby uric acid will not be carried to the nephron. Instead, it will be reabsorbed. That's why there is a high chances of hyperuricemia, high amount of uric acid in the blood, and that can even result in gout. Okay, uric acid crystals, sodium urate crystals will be deposited in the joints that will lead to severe pain and inflammation of the joints. That is what we call it as gout. Okay, and also there is a sensation to vomit, that is nausea, and allergic reactions can be seen like rashes, itching, urticaria. Am I right? So that kind of allergic reactions is also seen with the loop diuretics, and you will have problems like this. Yeah. So deafness, this is one of the specific toxicity, ototoxicity. Okay. So it will also disturb the cochlea, that is, it will damage your vestibulocochlear pathway. It will damage your vestibulocochlear nerve. Let me repeat, loop diuretics has a deleterious effect on the vestibulocochlear nerve. It will damage your vestibulocochlear nerve, and if you take along with other ototoxic drugs like aminoglycosides like streptomycin, amikacin, neomycin, gentamicin, tobramycin, framicetin. So all these aminoglycoside antibiotics, they are well known to cause ototoxicity. But when aminoglycosides are consumed with these loop diuretics, there is an what can I say, synergistic toxicity. Means the chances of ototoxicity or deafness will be very high. Okay, that's why you should avoid this combination. When loop diuretics are given, so don't go for aminoglycoside antibiotics, because both will have a dangerous effect on your vestibular cochlear nerve in the ear. Okay, so collectively they can cause more damage to the vestibulocochlear nerve, and it can lead to ototoxicity. Okay, and therapeutic uses, acute pulmonary edema. So this is what the thing is, acute pulmonary edema. Okay, so here what happens, as I told you, so in case of congestive heart failure, the problem is heart doesn't pump enough blood. If suppose this is your heart, so this is the aorta, for example. Okay, and here this is the vena cava. Please try to understand what is happening here. So here in congestive heart failure, ventricles will fail to contract properly. There is a problem with ventricular ejection. There is a problem with ventricular contraction. Okay, so here the problem starts, especially this is left ventricle, LV, and this is the right ventricle. And let me tell you why there is a pulmonary edema. I think you know that. So when ventricles fails to contract, blood will not be completely pumped out of the heart. Still blood accumulates in the ventricles. Okay, so blood will accumulate in the ventricles. So one of the major problem is left ventricle. Left ventricular failure is very, very common. So we know that left ventricle receives oxygenated blood from oxygenated blood from pulmonary veins. Pulmonary veins supply oxygenated blood to the ventricles. So this is, I will write as PV. PV is nothing but pulmonary veins. Okay. And here the problem is when the left ventricle is completely empty, when the left ventricle contracts properly, entire amount of blood accumulated in the left ventricle will be pumped out. But if blood already remains in the ventricle, left ventricle, at the end of each contraction, because of poor contraction of left ventricle, that is with congestive heart failure. So now what is happening? Fresh blood when enters into the left ventricle, already certain amount of blood is accumulated in the left ventricle. So that entire amount of blood will not have a space to enter into the left ventricle because of already presence of certain amount of blood in the left ventricle due to the poor heart contraction. So certain amount of blood will enter here up, to its capacity. Rest of the blood, extra blood, which has to enter into the left ventricle, it will go back. It will go back into the lungs. It will go back into the lungs. Okay. And as a result, at the end of each contraction, fresh blood will be added to the left ventricle. Extra blood will go back into the lungs and it will build up. If the left ventricle is completely empty, then sufficient amount of blood will have enough space to enter into the left ventricle. But if left ventricle is already having blood, the incoming blood will not from the pulmonary veins, it will not have space to enter into the left ventricle. It will go back and build up in the lungs, and that is what we call it as pulmonary edema, that results in sudden and severe accumulation of blood in the lungs. That is called as pulmonary edema. If you take an X-ray of such an individual, you can see large amount of water droplets in the lungs, and that will seriously interfere with breathing. Okay, and there you can that excess blood accumulated in the lungs can be removed by using diuretics. Loop diuretics can be given so that the blood volume decreases and excess edema that has been occurred in the lungs, that can be solved, or that excess water can be eliminated. And severely in chronic heart failure, you can use, because if the blood is accumulated more in the ventricle, ventricular size will increase. Okay, and what do you call that accumulation of blood in the ventricles? I think I have used the word, sorry, that is what we call it as preload. So I have used the word as preload. Preload is nothing but the volume of blood that is accumulated in the ventricles at the end of the diastole. If preload is more, heart size will increase. When heart size will increase, automatically there is a pressure generated on the myocardial cells. Myocardial cells will stretch. When the myocardial cells will stretch, when the heart size increases, you may ask a question, sir, what happens? Let the heart size increase. What is the problem? There is a problem. If the heart size increase, as we know that when we are small, when we are kids, our food consumption will be less. But when we grow old, as our physical, I mean to say that as physically we will grow, okay, as our body weight or body size increases, we demand more food. In the same manner, that can be taken as an analogy. So here, as the heart size increases, myocardial cell will stretch and it will also demand more oxygen. Like how we become bigger and we eat more. In the same manner, when the heart size increases, cell will stretch and it will also demand more oxygen. So that is the reason you have to reduce the size of the heart. Because if the size of the heart increases, you have to supply more oxygen. And here, when the heart is not pumping properly, when the heart is not at all producing enough cardiac output, so where is the blood to circulate? Where is the oxygen? Okay, hence, so you have to reduce the size of the heart, and when heart comes to its normal size, it gains its pumping efficiency. In a single contraction, it can pump the entire amount of blood. Cardiac output becomes normal. Okay, so that's why it is used in, just a minute. Yeah, here is the pointer. So chronic heart failure, and it can also be used in cirrhosis of the liver. So that is, so in cirrhosis, the problem is, it is commonly seen in alcoholics, where the normal hepatocytes in the liver will be replaced by fibrous tissue. Okay, I think whenever we have some wound or some cut on our skin, so finally it will leave a mark. After some time, some days we can see there is a mark, permanent mark on that particular wound. Okay, that is what we call it as scarring. So such kind of scar tissues will be formed in the liver, and that is of no use. Okay, that will not function. The major function of liver cells is to produce bile, is to synthesize bile, and another major function is to metabolize the drug, is to carry detoxification. And the scar tissue will not carry any detoxification. And one of the major symptom of this cirrhosis is ascites, means accumulation of fluid in the abdomen. Okay, fluid will be accumulated in the abdomen, and that fluid has to be removed out, and that can be done by diuretics. Okay, and here nephrotic syndrome. Nephrotic syndrome is a condition in which there is an excess secretion of proteins in the urine. Protein which should not be secreted, there is an excess amount of secretion of proteins, especially albumin, in your urine, and one of the major symptom is edema. So there you can use in renal failure associated with edema. You can use in hypertension where blood volume is very high. You can reduce the blood volume by increasing the sodium and water elimination through urine. And you can also use in hypercalcemia. Hypercalcemia, as I told you, diuretics will increase excretion of calcium and magnesium. So if there is a problem with kidney stone, if there is a problem related to kidney stones and all, so that calcium which has been deposited in the form of stone or crystals, that can be eliminated along with sodium and water by using loop diuretics. That's why it is also beneficial in kidney stones, and along with blood transfusion in severe anemia to prevent vascular overload. To prevent vascular overload. Sometimes in severe anemic patient, so blood transfusion will be done. Okay, in order to, I mean to say that in order to bring back the blood volume to normal, or in order to bring back the hemoglobin to normal. Okay, but if during transfusion, if the blood volume suddenly rises, because these individuals require frequent transfusion, so blood will be transfused in many bottles, okay, several times. And during these circumstances, if suddenly if there is a sudden increase in blood volume, okay, and that immediately that increased blood volume has to brought to normal. Okay, so earlier the person was hypotension because of anemia. You have to bring it to normal tension by increasing blood volume. But if blood volume goes above normal, then once again the person will be converted from hypotension to hypertension. Okay, so that has to be brought to normal. Got it? So that's why if there is any increase in vascular overload, keep a small dose of loop diuretics with you. Just give an injection. That vascular overload will be reduced uh, by reduction of blood volume, by elimination of sodium and water from the urine. Okay, so that completes your loop diuretics. Okay, so I will stop now. I hope the video was informative. So you just watch this video, and if you have any doubts, let me explain after this video. Okay, I will display this video. So later you can ask doubts. Okay, okay, okay. Thank you very much.